supported. So I'm going to talk about stigma as a determinant of health. And before I jump into that, I'll just talk about the social determinants of health. And these are essentially the non-medical factors that influence health outcomes. And they're the conditions in which people are born, they grow, work, live, and age in. And the wider set of forces and systems sort of shape the conditions of our daily life. And these forces and systems include the economic policies and development agendas, social norms, social policies, and even the political systems. So when we think about the social determinants of health, these are fundamental in improving the health and reducing long-standing inequities within the health outcomes of many folks in our community. And there's a diversity of experiences that, for someone who uses substances, they maybe could have a job, they might not have a job, they could own a home, or maybe live in precarious housing situations. They might struggle to find food, or they might be educated. They might have a disability. They might have access to a doctor, or like many folks, struggle to find a doctor. And so the health of people who use substances greatly varies. And because of this, we need to consider how we work and interact with people who use substances. And one of the issues that stands out is social exclusion. And in other words, this is stigma and discrimination that many people who use substances face. So to define stigma, this is essentially the unjust devaluing and discrimination of people. And it can occur at various levels, at the individual level, where individuals experience self-stigma, they hate themselves or devalue themselves. At the interpersonal level, this includes social stigma or the putting down of others from one person to another. And then at the structural level, this is systemic stigma, where we perhaps may develop and enforce exclusionary policies, practices, and even use derogatory language. Stigma can impact people who use substances in various ways. So first, it can influence social isolation, diminish their self-esteem, and also develops feelings of shame. And for people who use substances who experience stigma, they may even delay entering treatment or even ending their treatment early if they experience stigma from their healthcare provider or service provider. Stigma can contribute to continued use of substances and almost lead to an almost twice the chance of having an opioid overdose. People who use substances who experience stigma may avoid even getting healthcare or social services in general. And because they delay accessing healthcare services, they end up in the emergency room. And all of these lead to worse health outcomes and poorer life expectancies. A few years ago, Brant County Health Unit conducted a research project with people who use substances. And one of the themes that we found was a pathway or a cycle for substance use. And this refers to the different ways that individuals enter this cycle of substance use. And substance use tends to have a major impact on individuals' lives, including the experience of stigma, which often contributes to further substance use. 11 participants of the 15 talked about using substances when they were teenagers or even younger. And it started out as experimentation, but then it turned into frequent use because of trauma that happened in their lives. And this includes death of a loved one or even physical sexual abuse. As you can see in this cycle, the impact of stigma that our participants talked about relates to this experience of rejection, isolation, guilt, shame, fear, and even degradation. And because of substance use, this leads them to a lifelong experience of addiction or substance use disorder, damaged relationships and isolation from the people that care about them, the experience entering a life of crime or even going to prison. And then, of course, they talked about being locked out of opportunities because of the substance use that they had in the past. All right. The next item we'll talk about is harm reduction. So when we talk about harm reduction, it's about reducing the risks related to substance use. It's also acknowledging the fact that perhaps some people just cannot stop using substances. And so the idea of requiring abstinence to, to get treatment is not a realistic goal for many folks. And so what we need to do is meet them, these people who use substances, where they're at, whatever their life circumstances are, and identify incremental change. And as part of supporting these individuals, it's about making sure that we are engaging with them in a non-judgmental way. And of course, not requiring them to stop using substances immediately before we can actually help them. In Brant and Brantford, we have we implement a number of strategies, and we are planning a few other strategies that are seeking to engage people who use substances and apply this harm reduction principle. And many of these strategies that are listed on this slide, we will talk about and within the panel discussion. Okay. Before we enter the panel discussion, does anyone have any questions about stigma or harm reduction? So I'm not seeing any in the chat or any hands up. So I'm going to sort of introduce the panel, and each person will ask questions, and they'll respond with the kind of work that they are doing or hope to do to address harm reduction and substance use within our community. So the first person I have is Randy Roberts, who is a person with lived experience from the Brantford Substance Users Network. I have also Mary Jo from the AIDS Network, Julie Smith from St. Leonard's, and then Rachel and Dr. Dahlman from the Grand River Community Health Center. So perhaps the first question I'll pose to, I'll start with Mary Jo. What does harm reduction look like at your organization? And how do you help people who use substances through the work that you do?
Sorry, Tin. Just finding my right buttons here. So hi, thank you, Tin. My name is Mary Jo, and harm reduction at the AIDS Network. It looks like our goal is to help folks avoid sharing needles and equipment to prevent bloodborne infections such as HIV and hepatitis infections, and also to reach those in more rural areas. So I work on the VAN. This is through the VAN program. It's a mobile harm reduction outreach program. So what we do is we meet people where they're at, and I mean physically where they're at. People call us or text us, and or during our outreach where we just hit the streets and talk to people. They provide us with, first we have a conversation, just offer water, offer hats this time of year. But then we tell them, who we are, what we have, what we do, and we provide them with the supplies that they may need, which includes anything from sterile syringes to naloxone, information and materials on safer drug use and safer sex, resources and referrals to other resources in the community, social services, drug and alcohol treatment centers, that sort of thing. Essentially, we're building relationships with folks in the community, treating them with the dignity and respect that they deserve. It's a confidential service, and we don't just cover Brant, but today we're talking about Brantford, but we cover Brant, Haldeman, Norfolk, and Six Nations. As I said, we will deliver the supplies, harm reduction supplies that people request. We don't have limits. Research has shown that it is best practice not to limit people on the resources that they need. Otherwise, they will reuse when access is limited. And so best practice is to ensure that we give people exactly what they want, nothing more, nothing less. We want to reduce and eliminate the barriers to harm reduction services for people. Both, like I said, in the immediate community of Brant and surrounding areas. Did that totally answer your question there, Tin?
Yes, yes.
Okay.
I'm going to ask Julie Smith to talk about the programs that St. Leonard's offers.
Hi, thanks for having me on today's panel. Much of what Mary Jo had said around approach is similar for our organization. So treating people with dignity and respect, and really making sure that their experience when they access our services feels welcoming, they're feeling comfortable, they're not feeling judged, and that they can be who they are and ask for what they need. So it's really important for us to approach it that way, person-centered, holistic, not treating the person like a person and not their substance use. Working with people at different stages of change in their process of change. So, people can come in, maybe they're not sure what they need or want to do, and they just want to explore that. Maybe they're being mandated to access services, and that's okay. It doesn't matter what brings them in the door. It's the fact that they're there, and we want to work with them on what they want to work on. So providing options that, meet their needs, their goals, allowing them to guide their own care is important to us, set the goals that matter to them, whether it be specific to their substance use or other life areas. And really acknowledging, as Tina mentioned, that we know that we provide services that individuals may not want to change their substance use or ready to change their substance use. So making sure that we're providing those options. So we have many programs to support harm reduction and don't require abstinence-based goals, and we really approach it from a client-centered approach, meaning individuals can come in with either goal. And so we don't require people to stop using substances in some of these programs. And so the one program I'll talk to you about is one that I work directly in, and that's our substance use and concurrent disorder program. So concurrent disorder being dealing with substance use and mental health at the same time. And so in that program, again, it doesn't matter, what's motivating you to come in. It doesn't matter what stage of change you're in. And so in that program, we would be supporting all goals and working with clients where they're at and with what they want to change. So providing intake assessment, talking about some recommendations, but developing a support plan collaboratively with that individual about what they want to work on and, what supports exist, connecting them to other supports in the community, connecting them with individual and group counseling that we offer, making referrals to day and residential treatment. So really focusing on the individual. And now we also provide some family support. So for a loved one who's supporting an individual struggling with substance use or concurrent disorder, we provide individual and group support. And so part of that is providing education information on harm reduction, what that is, what that looks like, as well as abstinence-based goals, and then looking at how they can support themselves during that process as well. We have other programs to support harm reduction, and that's through our addiction supportive housing program, the work that we do in collaboration with the hospital around the rapid addiction support team and the case management piece that we provide, and the work that the Brantford downtown outreach team does. We also have 2 harm reduction supply program sites and do distribute naloxone. So our two sites currently are the 133 Elgin Street, which has been open throughout the pandemic. And then we have a site here at 225 Fairview, which we're looking to reopen in the new year. So there we'd hand out harm reduction supplies and naloxone kits. And we also, distribute supplies and naloxone through the Brantford downtown outreach team, through the case management work we do and at our withdrawal management program. I'll touch on 2 more programs specific to substance use, and that's our withdrawal management program. Sometimes people who use substances may access withdrawal management to take a break from substance use. They may not have a goal of stop using entirely or ongoing at the time, and that's okay. They may have different goals for different substances, and we will work with them in establishing a plan to connect to services that will reduce the harms. For example, connecting them through the harm reduction supply program, providing naloxone, connecting to counseling. And then lastly is our residential program. So although while people are attending the residential treatment program, they must be abstinent, they do not have to have a long-term goal of abstinence. So they may also have different goals for different substances. And we work with people to create independent support and transition plans that align with their longer-term goals. So there's lots of options that are harm reduction based, and it's purely on what the individual is ready for and wants to change. Thanks, Tim.
Thank you, Julie. I'm going to ask Rachel or Dr. Dahman to speak to the Grand River Community Health Center's in work that they do to address harm reduction within the community.
Sure, so I can start it off. We have recently been pursuing an application for consumption treatment services, which I think we're going to get into in a bit. And we've also been working on distributing naloxone and doing some other work connecting with people who use drugs in the community. So some of the ways we do that are through our outreach station, which is basically a cart we set up outside and to connect with folks and get them access to snacks, to other resources, to showers, and to naloxone. So we do quite a bit of outreach work as well. We have folks who are nurse practitioners and nurses going to local shelters. And yeah, so quite a bit of outreach work connecting with folks who use drugs who are living in different circumstances, and then referring them to, of course, some of the services you've already heard about. But yeah, there's also other things in the works that we're going to probably talk about in a bit. Dr. Dahman, do you have anything to add there?
I think that's great for what the health center does. In primary care, obviously, we're often focused on the individual in front of us. And so one of our main roles as primary care providers is to help the individual feel respected and help them to know that there are these services available, and to connect them to all of the things that we've already talked about. And so, I think that Rachel otherwise has done a great job describing what the center is doing.
Great, thank you. And now that you've heard of some of the things that we are doing for harm reduction, maybe I'll call on Randy to speak to the experience of using services within our community and what you think has been very helpful for you.
Hi there. Welcome, everybody. I'm glad you made it today. There's several things that's been helpful. St. Leonard's, the work they do, the RAM Center, the work they do, and Grand River Community Health Center. But it's not enough. We've lost close to 150 people since 2017 here, almost 24,000 Canadians across the country since 2016. So clearly we're not doing enough, right? What we can do is we can stop criminalizing people who use drugs, right? That's the main thing. That's where the stigma starts. It starts off as children, we're taught drugs are bad, so people who use drugs are bad, right? Yet we see people with alcohol, playing sports and doing this and that, and they're looked upon where alcohol is the hardest and worst drug, bar none. Compared to everything. So we got to stop demonizing people who use drugs and get away from criminalization of those people. It's a health issue. It's not a, I was doing some research today and I found that Canadians spend 73% of our tax dollars dealing with illegal drug use on enforcement, 14% on treatment, 3% on prevention, and only 3% on harm reduction. Something's wrong with that picture, right? It should be kind of flipped around and maybe 3% on, we got to get some enforcement. It's needed, especially with the fentanyl. However, we always tend to penalize the ones who are using the drugs, where the ones making the money are left off. Safe supply is definitely really needed. It gets the poison, it gives somebody who uses opiates a choice from the poison that's on the street. And I call it poison because people don't know what's on there. There's been some carfentanil just this past month. I lost 2 friends again. So it's not really overdose, they're dying of poisoning. If you get a safe supply from a doctor, the benefits are not just you're giving somebody drugs, but you're also giving them connection to healthcare professionals that they never have. You're giving them a chance to see recovery, a chance to make a connection with somebody who can instill some hope. There's so much more for that. And same goes for consumption and treatment sites as well. You don't want to open drug use on the streets of Brantford, then we need a place where people can use it. It would stop on the needles that are discarded because of lack of bins. There's so many benefits around there, and sure, there's been a couple of negative ones. However, out of those little ones, the majority have been doing very well across the country from coast to coast. We need to hear more about what they're doing so well, right? Kitchener and Waterloo, I know, are doing very well, and same as Guelph, London. So there's a lot of good examples of how it works good, and our community can make it a great one as well. Another thing too, I guess, yeah, it's just getting back to that stigma. If we can start seeing people as human beings and getting away from calling people junkies or hoes or crack hoes, these are people's kids, right? Dr. Gabor Métis he was a downtown doctor in Vancouver, downtown East Side. And he wrote that he never met a girl with a heart addiction that wasn't molested as a child, right? And that is now a working girl, right? So if people can recognize that it's not a choice, right? Whoever thinks it's a choice, man, I try to stop breathing for a few minutes, right? It was a choice at the beginning, but there's all this medical knowledge out there that proves it's not. Now, that doesn't say that it can't go into remission, right? There's people like these organizations that can help do that. But another thing is, though, a lot of people think it's either or. So either we get a safe consumption site or we have treatment. But you got to have both, right? Because without a safe consumption site, those 150 people, and a lot of them were just young children, they can't have recovery. Their option is gone, right? So what about the next 150, right? As long as we can keep them alive, there's a chance that they'll find the recovery and make their way in. We can help them get into these organizations that, but then it brings me back to the wait list, right? The government's got to start spending more money for the treatment, right? Less money for enforcement, more money for treatment. Get people a bed when they want the bed, right? I remember once I went into the hospital and I was right suicidal and I had enough. And it took me a couple of hours sitting in a waiting room, upset, crying, going through a lot of I've got a concurrent disorders as well. So going through a lot of emotions, and they didn't put me in the room, they left me there. But when I finally got to see the doctor, the first thing that came out of his mouth was, how do you make enough money to get your drugs? And right away, it's like, what? So you see me as either a drug dealer or a thief? Is that what you're asking me, right? I told him that I'm suicidal, I want to kill myself. But he wouldn't admit me. He called a psychiatric nurse from upstairs down. And she gave me a taxi ride to a shelter that night. Right. So my window of wanting to get help was that small, and they just threw me away. Right. So I went to the shelter and I ended up I had 2 suicide attempts since then, within just weeks. And that's where people needs the bed when they want the bed, right? And they want help, right? We've got to get away from professionals stigmatizing us as well, right? So education, I'm so excited about this stigma campaign happening and how we can educate people and get change going on so that we can, save some lives, because if every children matter, then the children on our streets should matter as well too. A lot of them are Indigenous. 70% of BSUN's membership is now Indigenous, and they're homeless and they've got nowhere to go. They're dying. Yet people say that every children matter unless they're doing drugs, right? Then they don't matter. So I call crap on that one. They've gone through intergenerational trauma. Their parents were in those, and some were actually in there themselves, the residential schools, right? The trauma they're experiencing by living on the streets, that's added trauma. It's not easy. I've been homeless a lot, especially in Vancouver, and it's not easy, especially when you got a government that doesn't care or doesn't seem to care. All 3 of them, right? So we need more advocates to get out there and to see us as human beings and want to help us, right? Because we don't deserve to die just because we choose a drug that's socially unacceptable than the one you're drinking right now, right? So, thanks.
Thank you for sharing, Randy. And Randy talked a little bit about the anti-stigma work that's happening. I do want to direct you to the Health Unit's website to the campaign called End Stigma Here, or Stigma Ends Here. So you can join by following that website. There are campaign materials that you can download to participate in joining that conversation of how we can end stigma. Perhaps I can ask maybe Dr. Dahlman about how we can address stigma from a service provider standpoint.
Well, I think that's a great question. Obviously, it needs to happen on the community level, as you're already discussing. But a lot of times individuals also, I think, need to hear and be validated and to know that the person sitting right in front of them, that their healthcare providers respect them and are not judging them in any way. The other, and to help to make sure that they know that we believe that this is a medical condition, and that addiction is not, as Randy said very powerfully, not a choice, and that people who use drugs often feel they cannot stop, and we have to recognize it as a medical condition. And help the community to see it that way as well. And to also let our patients know that we see it that way, and that's why we want to help.
Great, thank you. And I'm going to ask Julie to speak a little more about the kind of psychosocial supports that are being done, and what is actually, what have you found to be helpful for people who use substances?
So, I mean, psychosocial supports, again, going back to caring and seeing the whole person. So focusing on physical, mental health, social connections, spiritual needs, and really includes any support that people receive to protect or promote their mental health and psychosocial well-being. So that could be, things like counseling, individual and group counseling, peer support, case management, housing support, education training, self-help supports. So those are some examples of what it looks like. And what was the second part, Tin, of your question? Benefits?
Yeah, the benefits to people who use substances.
Yeah, I think it really fosters, the ability to support people in exploring their circumstances. And I think it's really important that, as already mentioned, that people feel heard, validated, accepted, and really given a space for them to explore that, right? And to not focus on the substance use, but focus on everything that's going on, and really focus on what goals or changes that they want to make for themselves. It can create some structure and stability. I know just in my own clinical work in the past, clients talking about, that need for structure and stability, and, a lot, change is hard, right? A lot of, if we think about change for ourselves, let alone a situation where you're struggling with substance use and mental health, it really is something that is tough and can't always be done alone. And reaching out for that support is so helpful in terms of just, your recovery journey, what that might look like, what that might mean to that individual. And really, it's an option that is respectful and customized for that individual. So I think it just provides, as I said, that support, that structure, direction, guidance, but people are the drivers of their own recovery. Sometimes they need guidance, support, validation. You can go on and on, right? But that's kind of what comes to mind for me, Tin.
Well, thank you for that. Maybe I'll ask you a follow-up question.
Sure.
As service providers, people who work with or may be in connection with people who use substances, how do we start that conversation with individuals to engage them in psychosocial supports, or even direct them over to programs that support individuals who use substances?
I think by having an open conversation, recognizing that, again, people are at different stages of change. So if they're not sort of at that point where they're ready to commit to, abstaining or changing their use, it's not expecting that from them. So I think it's really, approaching the conversation in an open way that's caring and respectful and allows them to, have some control over the next steps, right? That isn't, attached with, all these conditions that need to be met. And that can sometimes be challenging because sometimes, depending on the circumstances, those exist, right? But not focusing so much on them, but, coming at it from, like, again, the approach that we often talked about, with hope, with options, with exploring what's out there. I often say, let's go through the intake assessment process and see what it says. Let's see, what comes out of our conversations in that process. And, the rest is up to you, right? You choose what your goals are, and together we come up with a plan that is about what you want to do. And I think when it's approached that way, people are sometimes surprised, again, we can present all sorts of options depending on, what the individual wants to do, but it's really customized to where they're at. So what stage of readiness they are, their level of motivation, and, breaking it down sometimes into smaller steps, because it can be really overwhelming. And shorter term goals, maybe down the road, they want to make significant change, but not right now, they're not sure, and that's okay. And being accepting of that is, I think those are some of the things that come to mind. I think it comes back to what Randy had said, and very well said, like treating people like human beings, and thinking that, I often think, they are someone's mother, father, child, and it's very important that we see the person in front of us and not what they're doing. And I think when people are treated that way, it saddens me to see that they're surprised by that, because I know their experiences in those cases haven't been positive. But for me, it's like I said, if we can change that for them, then, it shows that there's other possibilities out there. And I think hope is a big thing, and why I feel strongly about, some of the work that's Randy's doing, and, the connection with peer support and others that have had lived and living experience, because people often talk about, how helpful that is, or group counseling where, they're connected with other individuals who they can relate to, or that had similar experiences, or, present a different perspective. So for me, I think that's a big piece of it as well. I'll end there. I could go on and on, but.
Thank you, Julie. I'm
You're
just
welcome.
going to do a quick pause just to remind folks, if you do have questions, you can put them in the chat or put your hand up and we'll get to your question. Oh, Peter.
Can you hear me okay, Tim?
I can hear you, yes.
So my question, I wanted to break the ice here. So my question is about the stigma associated with an intervention, and that's a harm reduction intervention. I'm fascinated, like, you probably won't second guess your cardiologist on what he recommends as an intervention, but you'll second guess your addictions practitioner in pursuing harm reduction. And I have trouble understanding that thinking. I'm curious whether any of the panelists would agree with me. And I also sometimes reflect, like, harm reduction can apply to non-substance use issues. Like, I think of diet and weight loss. And I think, we don't all eat carrots and celery, or at least I don't. Like, we all, cheat sometimes. Do you think that's analogous? And my final point on harm reduction, too many people always equate it to being enabling of substance misuse. how do you break that cycle of thinking? So a couple points, I'd welcome any of the panelists to respond.
I can speak to the last point a little bit. I think what a lot of the literature has told us over the years about harm reduction interventions, and when I say harm reduction interventions, that's the entire scope, is that there's no association between introducing harm reduction in a community and increased drug use. So I think a lot of what we can do to address some of the stigma around harm reduction is providing education about essentially the facts and what the literature tells us. There's never been a scenario in a community where a safe consumption site has been introduced and then injection drug use in that community has increased. So things like that, I think, are a great start, just general education, because we do have that data available, and that data is, again, global. It's not just Canada specific. So that's a great way to start from my perspective. I don't know if anyone else wants to chime in.
Just off of what Rachel said, that again, to that last point, Peter, you know, just because we put out ashtrays, it doesn't encourage people to take up smoking, right? Because we put out garbage cans, it doesn't mean people are going to just find stuff to throw in it, you know? And so we got to get away from that mindset that just because harm reduction services are there, that people are going to start substance use, or it encourages substance use. All it does is it gives people the tools to do what they are going to do anyways, safer, in a safer way. And that's all it's about. So, I mean, you know, our doctors can tell us we got to start eating healthier, you know, but, you know, we know that might be the right thing for our body, but it doesn't mean we're going to do it. You know, our doctors will give us those tools. Unfortunately, they don't provide us with those veggies that we need, but they tell us what we need. But we have the autonomy to choose that, right? And that's about the respect and dignity of people, choosing what's right for them. So that helps to decrease the stigma when you look at it in that sense. Just we have to get away from, and this is might be like way out there thinking, but we really have to get away with, you know, expecting the goal to be abstinence. You know, once upon a time, you know, prohibition existed, and look where that got us, right? Like people drink because they want to drink. People smoke because they want to smoke. People use drugs sometimes because they want to use drugs. And that's okay. Unfortunately, society villainizes them because it's illegal, because it's not a legal thing to do right now. Just, you know, years ago, weed was illegal. And here we are now, you know, it's harder to access. There are safer strains out there. The government has control over it, you know, so I envision a future of safer access to safer drugs, you know, and I think that's going to help too. I don't know if that helped with what you're asking.
Thank you, everyone. And just to add to all the great analogies around harm reduction, one thing that public health toots is around safer sex education, ensuring that people receive the proper education on how to protect themselves from sexually transmitted infections, as well as, you know, unplanned pregnancies. And so we make sure that we give our teenagers and youth the tools that they need to practice safer sex, to prevent disease transmission, and to prevent unplanned pregnancies. One thing that perhaps didn't get touched on from Peter's questions is how do we address stigma associated with some of the harm reduction strategies? How do we get, you know, practitioners to also buy into harm reduction, some of the harm reduction strategies that we are trying to encourage. Does anyone want to jump in there?
I'd like to speak to that because for those who don't know, I just came from the States where a lot of these harm reduction strategies are not yet legal or implemented. Some actually, when speaking with Rachel, I was a little surprised at some of the ideas that she was putting forward. And I did quite a bit of research. I've read about all the wonderful work that's being done in Vancouver and in other places around the world. And, it's easy once you see the facts and once you understand just what a great impact these strategies can have, not only on the individual patients, but also on their communities. It's easy to get on board, I think, as a scientist, as a medical professional. And so I think one of the big things that needs to happen is education at the entry level for healthcare providers, not just medical school, but everywhere with nurses and all of the and around the hospitals and other institutions to help. As Randy pointed out, there's a lot of stigma and a lot of prejudice that happens right in our healthcare facilities, and so educating people about just how these harm reduction strategies really can make a difference in our communities, not just the people of the communities, but people in healthcare, is essential.
Great. Thank you for that. I'm going to flip a question over to Mary Jo to talk about naloxone and how naloxone is actually helping and supporting in this drug poisoning crisis.
Thanks, Tin. So actually, we assume everyone knows about naloxone. Unfortunately, we just found out, it probably shouldn't come as a surprise, but it does. We just found out during NAW week, there are still lots of people who haven't even heard of naloxone. So we should never assume that everybody knows about this. So it rapidly reverses an opioid overdose, and so it attaches itself to the opioid receptors once it's administered, and blocks the effects from other opioids for 30 to 90 minutes. So it can quickly restore the breathing to someone who their breathing has slowed or stopped because of an opioid overdose, and it has no ill effects on anyone who does not have opioids in their system. So we give it out to save lives. That's it. It's an effective tool. It's a fast-acting tool. It's a life-saving tool. We take kits all across, like I said, Brantford, Haldimand, Norfolk, 6 nations. In Brantford alone, this past year, we have given out, after talking to the team earlier today and compiling all of our numbers, it was just over 4,000 kits this year, which is significant. Unfortunately, there were still too many overdoses. 1 is too many. So obviously we need to do some more education around this. We need to get it into the hands of more people, because it is fast acting. It's an immediate response to the toxic drug supply. So I see a question, do naloxone kits expire? They do. So typically the kits that we're giving out now will expire in 2023, but always check, there's an expiry date on the back of the kit. Check that. And with your kit, even I'm not a doctor. I will, say that, but if you have expired naloxone is better to use than no naloxone. because people's lives are on the line. So whatever we can do, whatever any community member can do to ensure or try to help another human being live, then we do it. We encourage it. So naloxone is easily administered. It comes in 2 different forms, both nasal and injectable. Right now, we're seeing more uptake in the nasal. It's been more comfortable for people to use. I personally have never had naloxone used on me, so I can't speak to how it feels. But the folks that I have talked to, some folks prefer the injectable, which is their prerogative. But most folks actually prefer to have nasal on hand just for ease of use and time saving. Anyone else can probably speak to that as well, but yeah.
Thank you, Mary Jo.
I'd just like to, thanks, Mary Jo.
Yeah.
That was great. If it wasn't for naloxone, there would be an extra 100 and was it 90 overdoses so far this year? So it's great. However, it's not the end all of everything. We can't just rely on naloxone, right? We shouldn't have to rely on naloxone. And that's where the safe supply would come in, where we can get more doctors on board. It would not only, prevent people having multiple overdoses, it would also, it would reduce a lot of crime. Think about it. You're giving people the drugs they need. What reason would they have to go and steal? They've got their money, they get to keep it. We give them supports. Save a lot of money on policing, courts, jail, probation, parole. Maybe then we can invest some of that money into treatment. And also, some of the precursors of maybe helping the children, who are traumatized right now, so that they don't have to turn to drugs like I did and like everybody else did, right? So, safe supply can do so many benefits besides getting rid of, that poison that's on the street. You would also get rid of a lot of the violent crime as well. The drug dealers won't have to come into town and collect money and shoot people up on stuff like that as well, right? So you could eliminate a lot of that by decriminalizing drugs and safe supply right across the board. And it's just about keeping people alive. Are we worth it? Yes, we are. The majority of people who use substances, 90%, maybe more, are active in the community. We work, we have jobs, we volunteer, we're husbands, we're wives, we drink a beer, or we, have a pill for a pain. But we're active in our community. Whereas what we see downtown is only a small percentage of it. Those are the people, my peers that are they need the help more than anybody. They're in crisis right now. Yet we victimize them, or we blame the victims, right? We blame them for our fault, for not sticking up to our government, for letting them spend our money that should have gone to treatment and mental health on other things, right? We did not stand up to all governments and say, no, the money's got to go into, you don't just let people out of institutions and then open the door and just let them go and wander the streets, right? And that's what we did, right? It's time to, take responsibility as citizens and say enough's enough, right? Let's get back to, protecting people, raising people, treatment. And if we needed a cancer treatment center here in Brantford, we wouldn't go to the population and say, have your say. And it's up to you to decide if we do this, right? So what gives people the right to say whether a life-saving treatment for myself, they have a right to decide if I'm worthy or not, right? Or the government officials, right? It should be a given. If it's proven and the facts are there, then it should be given to us, right? And there shouldn't be put limits on it either. only 21 centers. That means only 21 cities are worthy enough. The rest are going to die, and that's okay, right? We can't allow that to happen, right? But we do, right? We have to have a voice, and we have to realize that it affects us all. It affects us right down to every dollar that's spent. 73%. That's huge, man, on policing. And there's no need for it when you can just, you know, make it legal and give people. We made alcohol illegal. And that is one huge mistake when you look at the thing, the stats. I was looking at it today, and all stats point to alcohol and cigarettes as the most costly compared to all other drugs put together. The most crime is everybody, it was alcohol. Yet we're stigmatized because we do a different drug than, you know, what society deems right. So yeah, naloxone is a great thing, and I've had to use it several times this past summer. I wish I didn't have to. I give it out myself here, and I asked 20 of people that I've given it to. I get it a lot, but I asked them 20 out of that 20, have you ever used, or has you seen somebody who used the naloxone I given you in the past? And 18 have said yes. Half of those have used it multiple times. So, you know, naloxone is out there and it's needed, but it's not the end all, right? We can do better as a society. So.
Thank you, Randy. Before we jump into talking a little more about some of the things that Randy's talked about around CTS, I want to ask if Mary Jo or Julie want to respond to Shauna's question around, you know, getting a lot of kits as opposed to just one or a few.
Hi, Tin. So we typically don't limit anybody on anything. We don't tell people, you know, how much you need. No, you can only save 5 lives today, you know. So we're generally directed by what people are requesting. So we try and answer whatever the need is.
Same for us.
Great, thank you. And from public health standpoint, we do offer folks, you know, agencies that want to distribute naloxone. We can engage in a conversation and in an agreement to give naloxone to you so that you can reach your clients who might need naloxone as well. So if you do have questions or want to engage with the health unit to distribute naloxone to your clients, please certainly contact myself or anyone from the health unit.
And can I just mention one thing about naloxone while we're on it?
Yeah, for sure.
Is that I would encourage organizations to allow their employees to administer it. I live in social housing, and the employees here, anybody that's employed by the city cannot administer the naloxone, right? Which is, it's mind-boggling because it is a substance that children could take. It's safe for animals. I know of one person who, because I gave them naloxone, saved a dog with it. It got into it. So why, you know, organizations are denying their, you know, telling their employees they can't do that? It's wrong, right? So I would encourage organizations out there to look into it and educate yourself and allow your, I don't know if there's any legality thing because you're not helping somebody, but there should be, right? You're expecting an employee just to step over and walk away while somebody's, right? Just give them the naloxone. It's not going to hurt nobody. It's going to save a life, right?
Great. Thank you, Randy. There is a comment in the chat there that says that staff are able to administer naloxone if they are trained and feel comfortable to do so. So
and I guess maybe somebody did better. We need to educate the employees then. Yeah.
Because this topic has come up several times now throughout the panel discussion, I do want to pull on either Rachel or Dr. Dahlman to speak about, what is a CTS and the kinds of services that are offered or the supports that are offered within a CTS or consumption and treatment services.
I can speak to that briefly. So consumption and treatment services is the Ontario program name for what is commonly called safe consumption sites or safe injection sites. So essentially they provide a safer, hygienic space for people to use drugs that they've already obtained under the supervision of staff. So how it kind of works in the Ontario program is that folks arrive at a CTS location with their drugs. They're given sterile consumption equipment like needles. And if they like, they could be given education on safer injection or safer consumption practices. So there's kind of the intake process. Then folks go to a consumption room where there's a medical professional. Typically it's a nurse or a paramedic. They consume their drug of choice, however they choose to consume it. And then they go to kind of an observation space or a post-consumption space more accurately, where they can wait and make sure that there's no adverse effects. So no drug poisoning or overdose events. So it's a safer space for folks who traditionally would be using alone or using in public areas to actually go and use somewhere safer under the supervision of staff. And some of the benefits of the CTS model here in Ontario, which you'll see at different consumption treatment sites across the province, is that there are a variety of services available on site at a safe consumption site or at a CTS. So there's things like counseling, there's wound care. Again, as I mentioned, there's harm reduction education so that folks can learn to inject in a safer way. And there's often referrals to other services like treatments, detox, and things like that. So all of those things are available typically at a CTS location. And one of the benefits of that is that folks who frequently access safe consumption sites are more likely to then go on and access other types of services, including treatment, than they would be if they were not going to the site. So I think it's really important to acknowledge kind of the wraparound service model of a CTS. And that's kind of what it looks like in Ontario right now.
Okay, thank you. A question that has come up in the past is, can a CTS pose risks to the public? And what kind of impact might it have in the surrounding community where it's located?
Yeah, so I know there's several folks here who could speak to this as well, but one thing I will say is that there's no association from any of the literature available between the emergence of a safe consumption site and an increase in crime. So essentially, CTSs do not increase crime in a community. There's no association there. What we do actually see is a reduction in things like discarded needles in the community and in the surrounding area around the CTS. And we also see things like reduced public drug consumption, because again, if folks have a place to go that's accessible to them to use in a safer way, to be saved if they overdose, and to dispose of their used needles and things like that, then they will go there. So I think ultimately CTSs and safe consumption sites, what a lot of the literature is saying, and again, this is in Canada and elsewhere, is that they kind of deal with a lot of the issues that people are often concerned about when they associate, when they think about safe consumption sites. And I just wanted to add that something that's really cool that a lot of sites are doing in Ontario is they're staffing their safe consumption sites according to what the community needs are. So basically, if someone identifies that they've had, I don't know, ongoing conflicts between business owners or folks who use drugs in the community, stuff like that, if someone identifies that as an issue, then they staff the site accordingly so that someone can actually do outreach and connect with business owners, or go out and clean up needles, or whatever the need is, or whatever people identify as a concern. It can be addressed because there's now capacity to do so. So that's kind of my response to that concern, is that it actually addresses a lot of the issues that people bring up.
Thank you, Rachel. Dr. McDormand, I saw you had unmuted. Did you want to add anything?
Yes, I completely agree with Rachel. You know, just it not only reduces or doesn't show any kind of increase in crime. A lot of around the world, different countries, cities have looked at what happens in these communities after these sites open up, and there's no increase in any drug-related crime at all. And in fact, there's some decreases in crimes, and a lot of places have shown decrease in robberies and theft, and especially decrease in drug-related crimes such as public use or unsafe disposal of needles and things like that. And from, you know, they're just, from a personal standpoint, I'm a mother. I just came from a big city where my children played in playgrounds all the time. And we always, the mothers would scan for needles because we found them quite often. And it's because there was not a great safe disposal spot. We this one community advocated then had bins for safe disposal, and they worked. There, you know, as a personal anecdote, I saw much fewer needles in the playgrounds. And so whether you look at it from a very personal anecdotal standpoint, or from people who live in these communities, and from their personal experience is not professional at all the way up to the studies that have been done, the statistics that are followed. These communities show that these sites are beneficial, not harmful.
Thank you. Who operates and funds a CTS?
So who operates it can depend. In Ontario, it's frequently community health centers. And the reason for that is community health centers have a quite robust model of services that they offer, and traditionally serve some of the most marginalized folks in our communities. So it just kind of makes sense for them to provide that service. In terms of who funds it, first, in terms of the application process for a CTS, you have to first seek a federal exemption for the Substances and Drugs Act, can't remember it. And that makes drug use legal in a designated safe consumption area. So you seek that federal exemption first, and then you go forward with a CTS application with the provincial government, and that is for seeking funding. So the provincial government actually funds most of the consumption treatment services in the Ontario region.
Thank you, Rachel. Maybe while you're unmuted, there's a question in the chat. Perhaps you might be able to respond to that. How long it might take to get a CTS here in Brantford? What is the application process like?
Yeah, so that is a question. So it takes a bit. I would say on average, someone else should probably correct me, between a year or two is what I've been seeing in other communities, because the application process, both with the federal government and with provincial government, is very robust. And I probably won't go into it too much, but a lot of folks do preliminary studies, community engagement processes. You have to first establish all of the policies and procedures around a CTS. You have to provide justification for why a CTS should exist in the community. So some stats around overdose and things like that. So there's all of these things that need to be checked off when you go forward with an application. And Shauna, it doesn't necessarily have to have community approval for the question in the chat box. But we definitely have to work hand in hand with the community when it comes to implementing a CTS. So if the community does have concerns around it, you have to make sure that you are coming up with mitigating strategies or different ways to address those concerns effectively. And there does need to be city council approval for the implementation of the CTS. So that's something worth noting. So there's just a lot of engagement around the entire process. Yeah.
Thank you, Rachel. Are there any other questions around, say, CTS or any harm reduction strategies that we are engaging with in Brant or Brantford? Oh, Peter?
Well, I always enjoy these sessions, but these sessions are always, we got 25 people, so we're all singing from the same song sheet, and we have probably a lot of like-mindedness around this. But like, what's the best practice? And Rachel, maybe I'll direct it at you because it sounds like you've brushed up on the literature a little bit. How do you? What's the critical success factor to move a community towards the same understanding that's developing, on the Zoom platform? Like I'll give an anecdote. I personally had to navigate and understand the literature and the perspectives and get insights from everyone. You have to have your own journey of conversion and understanding around harm reduction, stigma, safe consumption sites. What's the key to moving a community around this? There's a loaded question for you, Rachel.
I don't know if this is a great answer, but I do know that in terms of reducing stigma in communities and changing perceptions of particularly things like harm reduction and drug use, it is about both it's a combination of education and having lived experience platformed. So that's what the literature says about reducing stigma that I can share. And so folks like Randy who come forward and kind of put a face to this issue that's so often stigmatized and who share their personal stories, because we're very lucky to have folks in our community who will do that. Combining that with the education piece, I think really helps to humanize the issue and to kind of get people on the same page. So both of those factors are key when it comes to changing public perception. That's all I really can say to that.
Can I just say, like, there are generally accepted some reasons for opening a CTS, and it's to save lives. So we know they save lives. So asking community members, do we want to do something that saves lives? It's to decrease the spread of disease, HIV and hepatitis C. So there's no opposition to decreasing the spread of disease, to link people with supports when they need them and with services to help them on their journey of, whether they want to stop using the drugs. And then, to actually create a safer community. And that last one is the part, I think, that we have to convince them that these CTSs actually create a safer community. And those are the four, and if somebody else has another one, let me know, but those are the four that I think of as the main reasons why we do a CTS, and why any community member would oppose those is beyond me. So we just have to convince them that those things will actually happen.
There was a question in the chat if there are counselors that might be opposed to a CTS. Are there ways of getting approval of a CTS in Ontario?
Technically, yes. So there is an urgent public health needs site, which is basically, even though it says emergency safe consumption site, I think it's always an emergency measure, but it's a more urgent way and a faster way to have a safe consumption site implemented. The issue being that gives you the federal exemption. It does not give you funding to run the site. And then everything is kind of due to like municipal regulations and bylaws and things like that. So if you're implementing a site at a certain location, I'm not sure if that changes that response.
I'd like to just add to that. When Rachel said we got to prove the meat, Brantford is above average across the country on the overdoses. We have been since 2017, when for a couple of years there we were in so high for ER visits, opiate related ER visits. We were 1 and 2 there for a couple of years. we're still high. Our deaths and our overdoses are still above the provincial and the federal medium. So there is a definite need in this community. And there's an urgency that because of COVID, it was taken away. I would have hoped that COVID would have gave us more empathy, understanding what me and my peers have been going through a couple of years before that, trying to save lives. But it kind of turned everybody where they all need a break now, which is I don't get a break, right? I'm on there every day, 7 days a week, trying to save lives. And we need to see the urgency of that, because how many more people have to die, right? How many parents have to finally recognize that when it's too late, that they could have done something, right? And if there's parents out there, I do want to stress one thing. People talk about tough love, and that was okay years ago, but we're in an age of fentanyl right now where it's not if you overdose, it's when you're going to overdose, right? And, you know, when you tell people, your children, get out and I don't want nothing to do with it until you come back, you know, not use drugs, that may be the last time you see that person, right? And it's happening a lot because of this poison that's out there. Support your children as best you can. I say harm reduction. You put your child in a car seat as soon as day one when they get out of that hospital. You know, why not? Because you want to keep that child alive, right? If your child has to use that drugs in your house and you have to sit there with Naloxone, if you want that child to live, then do it. Because I daily got parents who reach out to me and talk to me about losing their child, right? And the guilt they feel, right? And it just kills me, right? And nobody wants to, you know, their last words to be, you know, get out of my house, right? I want nothing to do with you. And then, you know, you do it because people told you that's the way to do it. It's not the way to do it. It's unconditional love, right? Set boundaries, but, you know, protect your children, right? And we got to protect our community's children too, right? Because every child does matter.
Thank you, Randy. I'm going to pose a question that has rolled around throughout the years. Drugs are illegal, so why not just incarcerate people who use substances?
That's worked. We've been doing that for what, like 50 something years now? How's that worked out for us, right? It's just cost billions and billions of dollars of tax dollars that could have went to maybe less taxes. That may help the conservatives. There could be a lot less taxes, right? Better healthcare, less lines, right? No more having to have our patients in hallways, right? So, you know, by recognizing it as a health issue and putting the dollars where it belongs, it's much better for the community as a whole, right? Everybody's better treated and a lot less money. It costs a lot of money to jail somebody. A lot less than it would be to put them in a treatment center and to support that person, right? And to build houses, right? We got to get away from that. I'm not a criminal just because I choose a different substance than you. You like to drink a beer, I like to do something else, right? And it's only illegal because of morality, right? People think they're doing best. Well, if you really want to save people's lives, then maybe decriminalize alcohol. Take a look at those stats, right? Yeah.
Thank you, Randy. Julie, do you want to jump in?
Yeah, I think Randy covered most of what I would want to say to that question. I think incarcerating people is not treatment. It doesn't eliminate substance use, and it doesn't address the underlying issues to use. So it criminalizes substance use rather than seeing it as a health issue, as Randy has indicated. So, I mean, it's long been proven that that's an ineffective strategy. And so I just, you know, echo what Randy has said and just adding a few points that support what he's saying.
I just wanted to quickly add that incarcerating folks increases their risk of overdose deaths. when folks are incarcerated and they don't have access to their regular supply of drugs, they lose the tolerance. And once they are then released from jail or from prison, they're much more likely to overdose when they go to use drugs again. And a lot of people do go to use again, because again, it's not treatment to go into jail. Another thing is incarcerating people increases stigma around them and leads to all of the things that you've already spoken to, Tin, and reduces their likelihood of going to seek treatment when they need it because they feel dehumanized. So I think incarceration in of itself causes a lot of these concerns.
And to add to the impact of incarceration, it reduces the opportunities for folks to have a better life. It puts a mar on their record, which then leads them, cuts them off from opportunities to improve their lives and their life outcomes. Are there any other questions? Maybe put them in the chat or hand up. Oh, Mary Jo, did you want to jump in?
Hi, Tin. I just wanted to, of course, echo what everybody else has said, but also I was just going to say that it creates this cyclical pattern of, the release, and because you have a record, you are at a disadvantage, and you end up being a target again and easily picked up and thrown back in prison or jail, incarcerated again. And it's just, we see this time and time again, like everyone else has said, it doesn't work. It hasn't worked. The war on drugs does not work. Let's try some be kind strategies. I don't know, some compassion strategies. I live in a sunny world sometimes, but I think we really definitely need a different approach besides incarceration, because that just sets people up for failure. It makes money for the folks that don't necessarily need the money, yeah. Thank you.
Thank you, Mary Jo. With the last few minutes, I'll see if anyone has questions, if you want to put your hand up or put them in the chat. Otherwise, I'm going to introduce you. So for tomorrow night's session, we will talk about some of these initiatives, but also initiatives that have arisen over the past year through the engagement surveys that were done in the spring, and then any other ideas that have arisen since in the past 6 months. We're going to talk about what the next steps could be or should be for the drug strategy, and what does it look like for the next year or two, alongside the initiatives that have been running this year through led by many of our partners. So if you want to join us for tomorrow, the link you should have for tomorrow night, and hopefully we will see many of you there. And I'll stay online if folks wanted to chat further, but I will stop the recording at this point.